Hello, everyone. Thank you for joining us for another webinar from Adaptiiv and one of our customers. Today, we have the pleasure of Garrett Baltz, a medical physicist from Scripps MD Anderson Cancer Center in San Diego, California, joining us to present on the commissioning process that Scripps went through in implementing adaptive software, as well as commissioning their 3D printing service. And he's also going to walk us through two patient case studies that they performed there as well. I'm the moderator. I'm Rohit Seth here, moderating this webinar. I'm the director of marketing here at Adaptiiv. We're also joined by Ellis Mitru, medical physicist here with Adaptiiv. And I can let Ellis say a couple words about himself before introducing Garrett.
Hi, I'm Ellis Mitru, medical physicist and product owner of the external beam radiation therapy side of the business. I've been here for about a year, and before that, I was a clinical medical physicist in Quebec, Canada.
Thanks, Ellis. Yeah, so like I mentioned, Garrett is a medical physicist from Scripps, MD Anderson in San Diego. He has a master's in science in medical physics from MD Anderson in Houston, Texas, where he also did his residency. And his specialty there was 3D printed bolus, which was also his thesis topic. So he has a lot of background in 3D printing and 3D printed bolus. So we're pleased to have Garrett, and I'll hand it over to you now, Garrett, so you can take us away.
Great. Thank you for the introduction, Rohit. And today I'll be presenting work on behalf of myself and Stephen Kersner, who is our Director of Physics here at Scripps MD Anderson. And just wanted to thank him for his help on this project, and really excited to show you what we've been able to implement in our clinic and our use with it so far. Here's a quick outline of the topics I'll be discussing today. First, I'll go over our clinical implementation process, which included our acceptance testing and initial commissioning of the software and 3D printer. And then we'll move into a couple of case studies that we've done that kind of highlight some of the unique areas that this bolus solution has really been able to help us in the clinic and provide value. And then we'll kind of go over sort of our standard clinical workflow and some things that may be different than other clinics are using the system. And I'll conclude with a summary of the topics we discussed. Okay, so first off, talking about our clinical implementation, and this process was really separated into three separate areas. The first was acceptance testing. And this is kind of very much akin to the acceptance testing you may do when you're accepting a new linear accelerator or other CT scanner equipment into your department. So this mostly included vendor supplied tests, which are testing the fidelity of the equipment and the ability of it to accurately print the bolus and make sure that it's functioning as expected. The next process was our commissioning process. So doing specific measurements and testing to verify that we were satisfied with the dosimetric accuracy of the bolus and make sure that we were confident to start using it clinically. And then part of that was also complete end-to-end testing where we used a phantom to construct bolus for and test everything from start to finish. Okay, so the first part of that process, as I mentioned, was acceptance testing, and there were three main areas that we checked during this. So Adaptiiv provided us with a STL file of this part that you see at the top. In yellow is sort of the design dimensions of it, and that picture of the blue is the printed part that we printed to test it, that is printed in PLA. So the first part is testing the geometric accuracy. So the part has all these known dimensions, and you measure it along all these axes to make sure that it's dimensionally accurate within 1 millimeter. And so we found excellent agreement with that. And then the second part is sort of testing the integrity of the material. And so that goes into the mass density. So making sure that the printer is printing the material and the part at the expected mass density for PLA. And then also doing a scan of the material and checking the HU uniformity, making sure that there's no voids or air pockets within the print, and testing that the printer is making a nice uniform bolus that has good, no voids. Okay, so after the initial acceptance testing, then we moved on to the commissioning process. And so again, like I was discussing, this is kind of where you want to now, in the very much the same way you would commission a treatment planning system to make sure it can accurately model your specific linear accelerator. You need to also do similar commissioning for a 3D printed bolus to make sure that your delivered dose is what you're planning in your treatment planning system. And the main area of concern in this is that 3D printed materials have been shown to require special characterization to be accurately modeled in treatment planning systems. And at the bottom, I've listed 2 of the many manuscripts available in the literature that you might use that have shown this effect. And it basically comes down to that 3D printed materials are not accurately characterized by standard CT to electron density tables, and this could be due to their non-biological materials and also sparsity of CT density tables. And so what this effectively leads to is that if you'll just take a scan of a 3D printed object, your treatment planning system will not necessarily calculate accurate dose in that material. And you'll see this in the percent depth doses because of incorrectly assigned electron density to the 3D printed material.
Can I just jump in real quick? I had a quick question there. So
yeah, sure.
Garrett, when you were evaluating the Hounsfield unit of the 3D printed material, did you only look at slabs, or did you also look at like, let's say, cylinders or something around it? I'm always wondering if what we're seeing could also be attributed to some type of beam hardening effect in the CT scanner.
Oh, that's interesting. No, we mostly looked at just slabs, like you'll see, and I'll discuss in a moment, that we used for performing the percent depth dose measurements. But yeah, I don't. Maybe if you had a big enough object, you would see some sort of beam hardening. But I think it's mostly to do with just the material not falling on the traditional curve.
Yeah, I'm sure you're right.
Okay, so moving on, in order to radiologically characterize this material, we decided to perform percent depth dose measurements in the material. So to do this, we constructed phantoms that were printed in each of the materials that we studied to use for bolus that Adaptiiv recommends. So this includes PLA, which is the blue and kind of clear phantom that you see on the left, and then cheetah, which is a semi-flexible material in white that you see on the right. And so the way we did this is we had the slab at the bottom. We designed an insert to fit a 0.125 cc ionization chamber that we had. And then we printed slabs of varying thicknesses that we could place in different orientations on top of the slab. And by doing this, we could obtain ionization readings at discrete, measurement points throughout the depth ionization curve, and that would allow us to construct a complete percent depth dose curve. And so we had slabs ranging from 3 millimeters in thickness, or I think 2 millimeters, 3 millimeters, 5 millimeters, and then a couple of 1 cm thick slabs, and also a 2 cm thick slab. So this allowed us to get good spacing density of the measurements throughout the percent depth dose curve.
What was the field size relative to the dimensions of the slab?
Yeah, so these slabs are 10 cm by 10 cm in the XY, and then we used a 10 cm cone, so it was kind of exactly lined up for that. And for our readings, we basically only commissioned 6 and 9 MeV electrons to be used for the bolus, and so we felt that using 10 cm thick or 10 cm dimensional slabs was big enough to have side scatter equilibrium for those electron energies.
Thanks.
Okay, so here we see the results of our percent depth dose measurements that we obtained in those phantoms. 6 MeV measurements on the left and 9 MeV measurements on the right. So you can see in blue, we did a CT scan of those phantoms and simulated our measurement setup. And those are the results of the percent depth dose measurement that we got within the Eclipse treatment planning system. And then in light blue, you can see our measured results. So that's sort of describing the difference that we see due to inaccurate electron density assignment by our standard CT to density, CT to electron density curve. So we kind of iteratively played with applying different density overrides within our treatment planning system until we got good agreement with our curves. And so you can see in the teal, the light green color is our final modeling within the treatment planning system. And in the tables below, you can see we had excellent agreement all within 1 millimeter of the important dosimetric quantities of interest that we look for in electron beams. And our final density overrides that we commissioned for our treatment planning system was 17 HU for the Cheetah material and 320 HU for the PLA material. And these have nominal densities of 1.019 grams per cc and 1.19 grams per cc, which is close to the nominal reported densities of the materials by the manufacturer, but it's not exact. So I think this is an important point that clinics that wish to implement this for them, it's important that they also go through this process as they may have, differences in their CT to density table with their scanner, their treatment planning system. And so it's important that you individually verify that you're getting accurate dosimetric results in your treatment planning system for your bolus that you'll be printing.
Garrett, did you think it was necessary to apply a stopping power ratio to go from the percent depth ionization to percent depth dose, or the effect was maybe too small?
We applied stopping power ratios and P-REPL corrections as well that are noted in TG25 to properly go from percent depth ionization to percent depth dose measurements. And so we used, those are applied in these curves.
Okay, great, thanks.
Okay, so once we were satisfied that we had good agreement of modeling our material, we moved on to end-to-end testing with a head phantom that we had. And we wanted to kind of mimic cases that had been previously done in our clinic, just to, one, allow ourselves to kind of get used to how the workflow for the bolus end to end, so we could train ourselves to use it clinically, and then two, just to see how it works for these cases and provide an example to our physician of things that the modulated bolus is capable of doing. So this one case simulates sort of an orbit cheek treatment that one of our patients had. So we scanned a head phantom and tried to copy the PTV onto that phantom. And we designed boluses in both Cheetah and PLA. And we ran the modulated bolus algorithm for both of those cases. And these are the results of the final modulated bolus. And you can see we have good conformality of the 90% isodose cloud. And we printed both of these boluses that we'll see later on to do in vivo dosimetry measurements by actually delivering the planned treatment and further verifying that our commissioning process and the material modeling within the planning system was correct. This is the second end-to-end testing case study that we decided to do, and is another typical example that we often, our physician likes to treat, sort of the nasal ala. And again, we planned this treatment both using Cheetah bolus and PLA bolus, and got really good conformality of the 90% isodose line, and printed both of these boluses to perform dosimetric measurements with in a mock treatment. So as I said, we printed both of the boluses for the nose and orbit PTVs in both Cheetah and PLA, and we performed surface dose measurements under the bolus using film and MOSFETs. and compared it to those points within our treatment planning system. And we got excellent agreement between the delivered dose and the predicted dose by the treatment planning system. And so this gave us great confidence in our commissioning process and our ability to deliver planned treatments as planned within the system.
Did you have difficulty fitting the MOSFET wire underneath the bolus?
No, so our MOSFETs, the wire itself is very thin. It's literally paper thin. And so it's pretty easy to slide it in there. The rigid phantom, it's not quite as forgiving, but especially for a patient, they're really easy to fit under the bolus. Okay, so moving on to our first case studies. This is the first clinical case study we did. It was actually the first case we did, so it's quite interesting for us. So this was a 60-year-old gentleman who presented with recurrent squamous cell carcinoma of the fingernail bed. And so the physician here was really concerned about treating the tumor volume, but he also wanted to spare dose to the bone, the underlying bone of the volume as much as possible. So this was kind of a unique case where we're both, trying to achieve pretty significant dose sculpting using a modulated bolus, but also trying to use it for sort of a non-standard clinical setup for this extremity, which is a kind of different case than maybe typical cases where a patient will be supine in a mask. So here you can see the final dose distribution that was delivered by our modulated bolus. So even though a finger is quite thin and you might want to think that 6 MeV electrons would be sufficient, we ended up having to move to 9 MeV electrons, mostly due to the depth of the PTV on the sides of the finger, without making the dose too hot proximally. So this prescription was delivering 70 gray in 35 fractions using 9 MeV electrons. And so you can see we kind of played a trick by including the foam support underneath the hand within the body contour. And this way, the bolus software would think to mold the bolus to both the finger and the underlying foam support. And that way we could get a nice tight fit against the finger and the support and mobilization that we're using for this patient. And we were quite pleased with how it turned out. The second case study is another kind of example of a very typical use case at our clinic, where it's treating the scalp. And this has traditionally been one of the challenge areas for using conventional flab bolus, is the convexity of the scalp often leads to air gaps between bolus, and it's very difficult to get conformality of the bolus to the treatment area of the scalp. And so our goal was to deliver a uniform dose to a large volume on the vertex of the scalp. And so we wanted a bolus that would reproducibly set up with minimal air gaps. And this case also provides an example of all of our electron treatments, we perform first day in vivo dosimetry using MOSFET measurements. And this is to make sure both the treatment setup is correct, as well as a kind of a third tertiary verification of our output, making sure that the dose is being delivered as planned. So this will, we wanted to be able to perform these in vivo dose measurements with our bolus. So here is the treatment planning system showing the final modulated bolus that we used. Again, for this case, the prescription was 70 gray and 35 fractions, and we used 9 MeV electrons. There were some areas of the scalp where there was some nodularity that required sort of thicker dose, thicker areas to transit, and so that required the use of 9 MeV, but we are very happy with the conformality of the dose distribution to the PTV. So here is kind of the uniquity where the advantage of the Adaptiiv software and planning solution comes in that we've really come to like here. And so this is showing how the software gives us the ability to perform really precise in vivo dosimetry measurements even more so than we were able to do before. And this is made possible sort of through the use of, just how the bolus is computer designed. So we are able to place reference points within the treatment planning software Eclipse at areas where the physician would like to perform in vivo dose measurements. And so this is very typical of what he would like to do on the first day of treatment, dose measurement along the central axis, and then as well as a couple dose measurements along the periphery of the field to see the delivered dose distribution. And the adaptive software is able to import those points from Eclipse and then place those on the bolus, and then you are able to create what's called a dosimetry pocket for those correlating to those measurements. And so the adaptive software comes with a couple pre-configured pockets. I think one is for the OSLD, the microdot for Landauer, and then I think there's also maybe a TLD capsule. But what's nice is it also gives you the ability to design your own dosimeter pocket. So that's what we did here. We measured the dimensions of our MOSFETs and designed a small rectangular pocket to be used for our MOSFETs. And so the middle slide is us placing those dosimetry pockets within the STL model of the bolus software. And then all the way on the right, you can see is the final printed bolus. And then we kind of go in after the fact and label the positions so that we're able to correlate those exactly to the planned reference points within the treatment planning system. And so we delivered the treatment on the first day of treatment, and we got a very good agreement with our in vivo dosimetry measurements. And it's really nice to be able to perform measurements with this level of precision, and helps us give additional confidence that the patient is set up right, that the dose is being delivered as planned. And so this is something that all of us and our physician have really liked about the bolus. So going off of that and kind of going off of the clinical cases that I presented, I kind of just want to talk about our kind of clinical workflow and how we've implemented it here at Scripps. So we start with our CT simulation, and this we scan patients using a 3-point setup that you might use for traditional image-guided therapy, but we use this. The patient will be set up to the markers, and then we'll apply planned shifts to get the patient into the exact position that we know, which is very important when you're delivering these sort of modulated bolus treatments. It's important that you're accurately setting the patient up as much as possible in the planned position. That way the dose is delivered as planned within the system. So after that, we kind of use the standard adaptive workflow that they provide, very good documentation on how to design the bolus, how to go through planning it, printing it, and all of that. And then once the bolus is printed, we go through a QA process where we sort of verify the dimensions of it. We weigh the bolus, and then we have a secondary software called Mesh Mixer that we use to get the volume of the bolus that we print, and using that we can calculate the mass density, and we make sure that it is within tolerance of the mass density we expect from that we saw in our commissioning measurements of the phantoms. So that's sort of how we verify the integrity of the bolus. And then once we're satisfied that the bolus is good, we move on to the treatment setup. So the patient using the points is positioned in the planned position, and then using the dosimetry pockets that we place within the planning system, the MOSFETs are put on the bolus and then applied to the patient, and we're able to verify both the setup and the conformality of the bolus through our in vivo dosimetry measurements. And that will give us good, confidence that the patient was set up as planned. Okay, so moving on to the summary of our experience, the advantages we've seen of the adaptive 3D printed modulated electron bolus solution. we found, the main advantages 3D printed bolus is that you can get bolus that conforms better to the patient than conventional bolus. And this has really helped us for these scalp cases that we've had where we had been using flab bolus, but the 3D printed bolus conforms much better to the convexity of the scalp. We're able to do sort of interesting cases for extremities where we can get reproducible positioning for sort of non-standard treatment setups that we saw in the finger case. The modulated electron bolus allows us to perform dose sculpting, very much kind of like how you're able to achieve with an IMRT treatment, which is nice for cases where in the past we sort of had superficial PTVs, but they were maybe too complex, and the physician would have to use IMRT. But now we're able to do it with electron treatments and sort of really spare dose to the normal tissue compared to IMRT treatments. And then again, we've been really happy with the ability to perform precise in vivo dose measurements using the reference points and the ability to print in the dosimeter pockets. And this is very powerful to us to be able to verify the bolus placement and that the patient is receiving their treatment as planned.
Thank you so much, Garrett. That was a great overview of your experience using the Adaptiiv software and commissioning your 3D printing service and walking us through those case studies. That was amazing. As always, great to see the clinical application of our software and 3D printing in the treatment of patients. I would like to add the dosimeter pockets that you were referring to. When the bolus is being treated, there's appropriately sized caps that are printed that actually fill in, so there's not a space or anything during treatment, which is nice to have, and they get printed automatically through our software. We have time for a few more questions. Thank you to everyone who've been asking questions throughout. Really appreciate that. We'll start with this one here. It probably applies to both cases that you just presented on, but what was the patient experience like in the fingernail case and the scalp case?
Yeah, that's a great question. So I found it really interesting that our patients actually are really excited and they find the whole process very cool, that we're using 3D printing technology to design this custom-made treatment device for them. The patients may have heard about 3D printers or, on the news or something like that, but never had personal experience with it. So they find the whole process very cool. And they actually, almost all the patients have wanted to take their bolus home with them after their treatment has concluded. So it's kind of a fun keepsake for them. But the patient experience has been very good. Compared to kind of in the past with conventional setups, you might have to use, a lot of tape, and it might be very difficult to try to conform a slab bolus or super flab to a scalp, and it might be, a little uncomfortable for the patient. We find it's a lot more both efficiency standpoint, which is good for us, but it's also good for the patient to shorten their treatment time. It's a lot faster to place this exactly molded bolus on, and then quickly secure it, deliver the treatment, and allow them to get on with the rest of their day. So we've had really good patient experience so far with it.
Thank you for that, Garrett. That was a great answer to the question. I always love to see the patients having the best experience possible and providing the highest standard of care. That's our goal. Next question is about the finger case specifically. How is the fit on the finger?
Yeah, that's a good case. It's kind of that's a good question. It's sort of a unique use case, but we found good fit on the finger, and the way that we designed it, to be able to fit against the foam pad, and we kind of gave it enough room to be able to slide up the finger. We found that there was good fit, and the patient is also able to, give you feedback on if it's fitting in his finger. And so we found, both with that, and then we also did in vivo dosimetry measurements with this. And so that gave us good confidence that it was set up as planned.
Awesome. And how did you immobilize the fit on the finger for that case?
Yeah, so again, we did do a 3-point setup on his hand using the lasers. So sort of like all of our cases, we first aligned the patient using the lasers, and then we apply known shifts. And then once we're confident that we're in that position, we place the bolus and then immobilize it with tape, and you know deliver the treatment. So.
Great. Yeah, it looked like there was only one piece of tape there, so not a lot of extra material being used, which is probably very pleasant, more pleasant for the patient.
Hi, Garrett. Yeah, another question came in here, but first I just want to say that I really enjoyed that presentation. You guys are doing some great work over there, and you keep it up. I'm sure that the medical physics and radiation oncology community are going to love seeing this type of work going forward. I was curious about how PLA and NinjaFlex. How do you decide between the two in the clinic?
Yeah, that's a good question. So we did commission both of them to be used as bolus, and we're confident in using both materials. But we've kind of internally decided that we like the cheetah material just because the ability of it, kind of the semi-flexible nature of it, we think you can maybe get slightly better conformality, especially for maybe scalp cases. So just so far, we've only been using the cheetah material for all of our boluses, and we've been happy with it so far, so we've been sticking with that.
Great.
Well, I'd like to thank you so much, Garrett, for your time today, and Ellis as well for helping moderate the session. We really appreciate yourself and Scripps MD Anderson Cancer Center, first of all, being a customer of ours, and secondly, using our software and 3D printing to, again, provide the highest standard of patient care and personalized care to patients. Like you said, it's really cool that patients get excited about the 3D printing aspect and wanting to take their bolus home with them. It's always music to our ears here at Adaptiiv to hear that. So again, thank you very much. And to everyone else, thank you for attending. Really appreciate the questions and your time today. And we'll follow up with answers to any outstanding questions that weren't answered today during the session. Thanks, everyone.
Thanks for the opportunity.